hormones are fluctuating rapidly in the mom-to-be's body. And those hormones, those pregnancy hormones, really directly impact insulin resistance and sensitivity. So you expect your glucose to go up higher, and it might move around and bounce around. And then during the first 4 weeks, at some point, you're going to notice you need more and more insulin. And so sometimes people, if they haven't taken a pregnancy test, are sure they're going to get their period because they're like, I thought it was PMS. I just keep more insulin, more insulin, more insulin. And then they take a pregnancy test and they're like, I thought I was going to be low. And then
Yes.
at some point in time, somewhere around between 4 and 8 weeks, it's a little different for each person, but usually by around week 6, but typically by 8 for sure. All of a
Mhm.
sudden start needing less insulin
Yep.
and less and less and less. You can get down to sometimes even a third of your pre-pregnancy doses in a pretty quick succession, which
Mhm.
you don't know is coming, can be very dangerous.
Welcome to Think Like a Pancreas, the podcast, where our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in this program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Please discuss any changes to your treatment plan with your personal healthcare provider before implementing.
Hi, and welcome to yet another wonderful episode of Think Like a Pancreas, the podcast. I'm your host today, Jennifer Smith. I'm a registered dietitian, certified diabetes care and education specialist with integrated diabetes, and joined again by Tavia, who is my colleague and kind of counterpart as we navigate helping a lot of people through pregnancy with diabetes. So, Tavia, do you want to introduce yourself and say hi?
Of course, of course. I'm glad to be back and talking again with Jenny, one of my favorite people in the world. So always glad to be here with Jenny. Jenny introduced herself as a registered dietitian. I am her counterpart at Integrated Diabetes Services, one of her counterparts, as a registered nurse, certified diabetes care and education specialist. So one thing that I enjoy about our conversations when we're working on creative problem solving for helping women get optimized management is from our varied backgrounds and experiences, pulling all the different pieces together from the dietitian's perspective, from the nurse's perspective, and from the CDCES kind of blended perspective. So
Yeah.
hopefully you all joining us today will enjoy and learn some new things about some of the processes and ideas that Jenny and I use every day.
Absolutely. And today we're session 2 or part 2 or just the next segment really in navigating pregnancy with diabetes. We started out last time with discussing what it takes to kind of really get to know your diabetes in a way to target blood sugar values and to really, delve into nutrition and activity management while you're trying to aim for tighter targets in that preconception time period, right? And one of the things that we left off in a bit before we talk and move into pregnancy today, we really wanted to touch base and talk about the value of technology. Technology has moved forward in the past, I don't know, I'd say 5 to 7 years really quickly. The change, right? Like almost every 6 to 12 months, we've got, hey, this is coming out, or this has a new target, or we've got a smaller size something or another, right? So understanding that even from a preconception standpoint, as you're getting to know how to target those tighter ranges and getting things all put together, technology is a big piece of that. And even if you're using just a continuous glucose monitor and you're still using multiple daily injections, you can absolutely still use this information to your benefit
Yeah.
because CGMs, if I had to pick, and somebody was going to take a piece of my technology, I would say, please, please, please don't take my CGM, my continuous monitor, because I can navigate my insulin with an injection as
Yes.
long as I can see where things are trending.
Agreed. Agreed. And with pregnancy management, when you're heading that way, it's all about the trends and the direction that your insulin resistance is heading.
Yes.
And being able to see it shift over time is there's just nothing more valuable in
Mhm.
order to optimize insulin doses and insulin regimens then being able to see that live data. So if somebody comes to me and they're thinking about becoming pregnant and they are not yet using a CGM or an automated insulin delivery system, I start with a CGM also.
Yep.
Because also, if you haven't used one, seeing your diabetes uncovered is somewhat shocking and can be stressful until you get some good education and get some familiarity with it. And
Mhm.
then it doesn't matter what system or injections that you're using, being able to understand what that information is telling you in the moment and then looking at reports over time to look at the trends is invaluable. You have to have that information to be as optimized as possible throughout
Yeah.
the process.
And you use a really good word that I also commonly use when talking to people about continuous monitors. Many people, I mean, myself included, to a degree, we look at the number. We do. And even if you're not doing finger sticks, which I wholly encourage, especially in preconception and pregnancy, still remembering that finger stick is the real time right now. This is what your glucose is.
Yes.
CGMs may be right on with that blood glucose meter value. They might vary a little bit too. And most often they do vary a little bit. But what is most important is that word trend.
Mhm.
We can
Yep.
really gain a lot from looking at trends while we're doing all of this preconception tracking and looking at food and activity and impact and what shifts where and why does it shift. Well, the trend on the CGM can help you make the best adjustments and will continue to do so during pregnancy, which is why there's value then getting to know your CGM on a very intimate level
Mm. Yeah. Yeah.
in the preconception time. And then, we fold into that. Many people now are using automated insulin delivery pump systems or AID systems. There are
Right.
several on the market. They all work a little bit differently.
Mhm.
So while you may understand your insulin, you have to take that understanding of insulin action and timing kind of another level, another step up when we use an AID system because each algorithm delivers or pumps out that insulin based on your CGM data.
Yep.
And the algorithms are all a little different, right?
Right. Right. And so approval, Food and Drug Administration approval for use in pregnancy, there aren't many that are approved for use, but that doesn't mean we don't use them because they
Right.
work better than not using them, and there have been several studies that show improved time and range,
Mhm.
improved rate and severity of hypoglycemia, and time above target during pregnancy on any of the AID systems. So
Right.
while they may not be officially studied and funded for testing for FDA approval, we see the benefits and the several studies have reported the findings to support what we've been seeing for several years. Now,
Correct.
Jenny, how often does it happen where somebody comes to you? This happens in my practice. Somebody comes to you, they're using an AID system, but it
Mhm.
isn't necessarily one that gives you a lot of features or functionality that is beneficial for somebody who is trying to conceive or may be pregnant. How do you navigate
Right.
through and discuss different options that are available? Or what would make
Yeah.
you throw that out there?
What would make me my own, I guess, professional looking at the data. We never set out to be data analysts by
No.
at eons, right? Eons ago when you were doing this, like when I there was data, but it was usually from like really basic continuous monitors and finger sticks. That's what
Right.
we had,
Right.
right? And now we look at a lot of data, so we really can spot trends and patterns and issues from the get go. So when we get started working with somebody, we can tell either the system isn't the right system for this person. And then we go down the avenue of, have you thought about this because of these parts of your lifestyle and how you
Mhm.
navigate? This one might be better. Or is the system just not optimized? Meaning, nobody's really helped that person get their settings, whether it's a basal rate adjustment, if that AID system allows that, or nobody's helped them adjust insulin to carb ratios. Maybe there was no pre-bolus timing discussion. There may be a multiple number of factors that could be adjusted, and then the system might just be fine. If they're not, then yes, the discussion is, well, did you know that there is this system that based on your unique way of navigating and your needs, this system might actually be a better fit? And would you ever consider switching to get better use.
Yep. Yep.
And I think you, as well as I know, and we'll talk about it as we go through the pregnancy part of this in a little bit, but there are also outside of the box thoughts on navigating within each and every pump system that there is. We will
Right.
always have to step outside of the box and use tools and tricks that the pump just can't overcome because of pregnancy hormones, right?
And because of the algorithm. So the algorithms themselves have limits. None of the algorithms have officially, you can't set, I want the glucose range to be 60, 63 to 140. You can't do that. And none of them do that, right?
None of
There's
the FDA approved products, no.
correct. Yeah, right. So sometimes it gets to where somebody is doing really an excellent job. They are doing all the work, but their algorithm keeps suspending to prevent what it sees as a potential low or below
Right.
target for where the basal should be delivered. And that basal suspension keeps pushing your blood sugar up too high. So if we're
Right.
talking strictly AID and not adding adjunctive additional medications, types of insulins to help support, then we might do something like switch it to manual mode overnight,
Right.
for example, or all the time, depending on the person and how their diabetes management is going with their system. Sometimes it
Right.
works better to have the algorithm running. Sometimes it works better to have it manual.
Correct.
Sometimes it works better to switch to a different system that just has a different algorithm that can
Mhm.
cover those glucose targets better with less
Right.
gymnastics from the mom to be to try to get to these tight
Yeah.
glucose management goals.
Yes. And I think what's valuable about, there is one system right now in the US that's approved in pregnancy. It's the Tandem. Tandem's
Yeah.
Control IQ is approved in pregnancy, and that's recent
Mhm.
approval.
Mhm.
Despite us having used it and Omnipod 5 and Medtronic throughout pregnancies, even though they're technically not approved, it's still their comparison of time achieved in range. It's improved compared to not using a system, right? So their approval is still not meeting technically pregnancy true targets, especially in the overnight fasting time period where, last time we talked about it being 63 to like 95 or 63 to 100, depending on what clinic you're probably in.
Hypoglycemia risk and, yep, what your
Correct.
healthcare providers are saying. Yep.
All of this, but none of the systems aim for that because the lowest right now of any of the systems is a 100,
Well,
right?
one of them is 87, right?
Twist.
Yes, because 'cause they're
Yeah.
using the algorithm, right?
They are, yes. And which again has not right now any true published studies in that particular system.
Right.
Europe has the CAM APS FX, which is approved in pregnancy and has been for quite a while, which
Yeah.
is nice. It's one of, but we don't have it here in the US in
Right.
use.
Nope.
So
Yeah.
acknowledging that technology essentially does have its place and having it set preconception, having things adjusted is very, very important. Knowing how to read your data is very important. And if you don't, then finding a clinician that can really help you look at your day to day. Because
Yeah.
as we move now into talking about pregnancy with diabetes and each of the trimesters as they shift and change, your data evaluation is going to be your best way to make adjustments. And those adjustments will likely need to be made even between visits with your OB care team.
And sometimes even weekly, and sometimes even twice a week, depending on
Yeah.
the situation, dosing adjustments, the settings in the AID system might need to be adjusted. And so
Right.
having a really firm understanding of what your AID system can and can't do when things are optimized, what are the guardrails in place? What are the safety limits that are going to make it do a hard stop? When will
Yes.
it provide an auto dose or when will it up titrate basal and when won't it? Understanding that will help you as the person who's trying to conceive or is pregnant best manage your glucose with that system.
Right.
So it's a really important piece to spend some time on ahead of time if you can.
Mhm.
Or the first visit you have with Jenny or I, we will dive down that rabbit hole to make sure you're on the same page we are. And so I think with that, shall we head on into what diabetes management is like once someone conceives? Should we go there?
Absolutely. I think, and it's a good kind of, segue honestly into knowing your system and knowing what you normally see and how things are working into that first trimester where if you have been planning on conception, you are likely one of the many who will test as early as possible for that
Yes.
faint positive line on the pregnancy test. And, with excitement, you get a positive, but then it's kind of now what? And I've experienced a lot of confusion and honest frustration in that first trimester where I don't know
Mhm.
about you, I'm sure you've heard it too, but a lot of women feel like their first trimester, they're supposed to just have low blood sugars all the time. Somebody told me that I was going to be really, really sensitive.
Yes.
And then I get to see somebody around 4 or 5 weeks and they're frustrated because it's the opposite. So,
Yeah.
so tell me, Nurse Tavia, tell me, not that I don't know, because I explain this to people all the time too, but
Right.
right, what's kind of happening post conception, and then there's a time period before a pregnancy test is going to turn positive, and from a diabetes perspective, what are we going to see happen up to what point in first trimester where things shift?
First, you're going to be super excited because you have that pregnancy test. Or maybe even before you take that early pregnancy test, you're going to get to this anxiety state. But maybe you won't now because you hear us talking. But what
Yeah.
happens to most people, and it's not true, you know how as we talk about these ideas, these concepts, each individual's experience is unique. So
Yeah.
some women will not see the things when their glucose that we're about to talk about, but it is very common. So the
Mhm.
majority of women will see this happen. You are diligent, you are doing all the things, your glucose is largely in the pregnancy target range, you're trying to conceive. And even before you take that early pregnancy test, or maybe within the first 4 weeks, you take it and get the positive, somewhere
Mhm.
in there, something shifts in your body and your glucose is bonkers. It goes up way elevated in a time that it wouldn't normally. It sticks up there and then it comes crashing down and you're like,
Yep.
but maybe my site wasn't working, and then an hour later I'm 50 or something, or
And
it'll
this
be
is where it's valuable to have had that preconception knowledge, because the wonkiness is going to be very visible. If
yes,
you had a strategy, breakfast, lunch, dinner, and you're not varying because you knew how well you had it contained, then things get wonky and you're like, it must
right,
be the insulin. It
right,
must be the site, right?
right, exactly. So if that's not your normal mode of operation, you will see it happen, and then you will think, maybe I'm pregnant. This is different from normal, but I thought I was supposed to be low. So you take the pregnancy test and then you're pregnant. And then you sort of panic because, oh my gosh, my glucose was above 250 for 2 hours yesterday and or something. I'm making the numbers up, but
Yeah.
this is what happens. So hormones are fluctuating rapidly in the mom to be's body. And
Mhm.
those hormones, those pregnancy hormones, really directly impact insulin resistance and sensitivity. So you expect your glucose to go up higher and it might move around, it bounce around. And then during the first 4 weeks, at some point, you're going to notice you need more and more insulin. And so sometimes people, if they haven't taken a pregnancy test, are sure they're going to get their period because they're like, I thought it was PMS. I just keep more insulin, more insulin, more insulin. And then they take a pregnancy test and they're like, I thought I was going to be low. And then
Yes.
at some point in time, somewhere around between 4 and 8 weeks, it's a little different for each person, but usually by around week 6, but typically by 8 for sure. All of a
Mhm.
sudden, you start needing less insulin
Yep.
and less and less and less. You can get down to sometimes even a third of your pre-pregnancy doses in a pretty quick succession, which
Mhm.
you don't know is coming, can be very dangerous.
Yeah.
So
I think it's a good place to even bring in, as we talked about technology, this is where looking at your data can be beneficial, because if you were using a system where you knew what your insulin needs looked like and it's automated either by adapting your basal or it's automated based on a basal that you had tested really well, and you can look at your data and you can see how much insulin's been being pulled back. Now you have something to use for an adjustment factor to go
yes.
in and adjust settings more accordingly because of what you're seeing, right?
Yes, yes. And this is a time period where during the beginning of pregnancy, in the first couple of weeks, it sells. There are no organs, right? So those higher blood sugars, although they can be panic inducing if you don't know this already, nothing is harmed, right? This is just, it's a normal physiology response. It's what happens. And
Mhm.
then when you know you're pregnant, or as early as possible between 4 and 6 weeks, if you can, that's where you're really going to make sure that you are getting your glucoses where they need to be for pregnancy targets. And that is where organs start forming. So organogenesis happens before a lot of women know that they're pregnant.
Hmm.
Whenever in the scheme of things you become aware that you're pregnant, my
Oh,
best recommendation is focus then. Don't spend any time worrying about the past X number of weeks because you
mhm.
can't do anything different than what was already done.
Right.
And chances are, unless you were coming into the pregnancy with an extremely elevated A1C, it's unlikely something untoward had happened during that
Correct.
early part. So if you're in the very beginning of that first trimester and organogenesis is starting, it's the key time. If you've missed the window is still open. So focus in and get your insulin doses all aligned and your strategies aligned, and it'll be worth it.
It will. And I think, in terms of what also happens in this whole time period, which many women come in expecting it to happen. But as you said before, every woman's experience is a little bit different, right? But
Mhm.
in this time of considerable change and how you're feeling, you're going to feel tired,
Yes.
more tired
So
than
tired.
so tired. Like I remember in my first pregnancy, I was so glad that I had a clinic space, that I had my own office that had a door I could close, because like clockwork at like 10:30 in the morning and about 3 o'clock in the afternoon, I actually put a sign on the outside of my door that said, in a business meeting, so that nobody would interrupt me. And I turned my lights out and I'd put my head down on my desk and set a timer for like 15 minutes. And I would just close my eyes because I was
So
so, so
tired.
tired.
Think Like a Pancreas, the podcast, is brought to you by Integrated Diabetes Services, where experience meets expertise, passion meets compassion, and diabetes care is personal because we live it too. Our team of clinicians, all living with type 1 diabetes, understands the challenges firsthand. We're here to help no matter where you are in the world. From glucose management to self-care strategies, the latest tech, sports and exercise, weight loss, type 1 pregnancy, and emotional well-being, we've got you covered. We offer consultations in English and Spanish via phone, video chat, email, and text. Want to learn more? Visit integrateddiabetes.com or email info@integrateddiabetes.com to schedule a consultation.
I mean, the other thing that pops in here too is nausea for many
Yeah.
women, but sometimes not at all. And sometimes it's extreme. But I would say that don't expect extreme, because it's a pretty minimal number of women. In fact, in
Mhm.
all the pregnancies I've worked with, I've only ever worked with 2 women who have had the hyperemesis,
Mhm.
had to be at the hospital for hydration and management of the nausea and everything. 2 out of, I don't even know how many women I've worked with.
Right,
And
right.
probably
Yeah,
you're the same, right?
exactly.
Nausea can be variable. It's
Right.
like most people, it's like morning sickness, but it's not in the morning like all the time. Most often it's just
An
like,
empty stomach nausea, which then makes it also extra challenging to manage diabetes because often the fix for that uncomfortable feeling is to eat something. And usually
it's
the
carbs
thing that makes it feel good or it's carby, it's like crackers and bread and mashed potatoes and gravy, mac and cheese, those things like
and
make it
butter
all go
on top.
away.
Yes.
Yeah.
Yep. Absolutely. Which,
Oh,
if you haven't, I've even had a number of women who have been more low carb to begin with and have noticed that that is no longer a desire, is almost stomach turning. And they've now had to learn how to add back some things that they just regularly wouldn't want, because that's all that calms their stomach. Now, there are certainly some approved supplemental types of things that can definitely help. I know Unisom is commonly prescribed as a take it in the evening.
mhm.
Also B6, which is commonly used. Things like drinking ginger tea during the day, which is herbal and is very safe during pregnancy. So or even non-carby things that you can get away with, as you said, to just kind of keep something in your stomach, a handful of almonds or a string cheese, just something to coat and keep that nausea kind of at bay can help, because then as you're navigating the drop in insulin needs and your likely possible aversion for other foods that you would have otherwise really preferred.
Right, right.
Right.
It helps navigate it.
It does. Yeah.
Yeah. Not everyone has hypoglycemia awareness, meaning not everyone feels when their glucose is going low. Many
Hmm.
people do. And so you would know if you do feel symptoms of low glucose, you know what your symptoms typically are.
Hmm.
And even if your sensor didn't yet beep at you, many people can feel, oh, I bet I'm dropping now. And that
Yeah.
would prompt them to look at their sensor and see that it's headed down. Many other people do not get any symptoms or mild symptoms, only at a very low number. Whatever the case is, whatever your baseline is, you cannot rely on that during pregnancy.
Right.
Hypoglycemia unawareness becomes more pronounced because of the hormone shifts during pregnancy, and people can have very severe hypoglycemia with minimal to no symptoms. So
Right.
it is really imperative. It's one of those should have already, because you take insulin, we would want you to already have at home glucagon and also glucagon that goes with you now instead of just leaving it at home like many people do. And also ketone test strips, because those will be important throughout pregnancy as well. So
Right.
if you are noting frequent lows in your CGM data, or as evidenced by the mass amounts of things you're consuming to prevent and treat lows, that means your insulin doses need to be changed. So
Hmm.
there's no reason to continue to have frequent and severe lows during first trimester.
Right.
Instead, really appropriately and in an ongoing fashion, your doses just need to be backed off. And then revisiting when and how to use glucagon. And if you live with someone else, training them on when and how to use it is extremely important. The goal is for it not to be needed, for there not to be any severe hypoglycemia episodes. But everything about diabetes is being prepared. And this is one of those really important pieces that unfortunately gets missed sometimes. And it's just a better strategy to have this safety net in place.
Yeah. And it's appropriate to bring up at the point where we're talking about insulin sensitivity and the nausea component that could be in the picture because you've prepared to eat a meal and you've bolused knowing that you feel fine. And then all of a sudden, a wave of nausea kind of comes through and you just can't take anything in. That could be an instance of, I just couldn't take anything and I may need to use glucagon in order to prevent a very significant low blood sugar, right? And
Mhm.
we often also teach microdosing for these particular scenarios where, while glucagon is seen as an ultimate rescue of you have passed out and you cannot help yourself, and you don't have to wait until you get to that point
Correct.
either.
So if you see it coming and you're like, this doesn't seem good, that's a
Yes.
perfect time to use it as well. And like you
Correct.
mentioned, if somebody is dealing with a fair amount of nausea, especially nausea with vomiting, then it does change how we're going to dose the insulin timing, and that can impair time and range. We have to balance out what's safest
Yeah.
and optimize based on each person's situation. And that's what we work with people to do. And that microdosing glucagon can come in and really save the day if someone takes a dose for a meal and then vomits. Like
Yes.
you can't put food in then. Like you just can't. It's not going to work. So that
Yes.
microdosing of glucagon can be very helpful.
We have a really good teaching tool that we use to help people understand not only what's the appropriate kind of glucagon to use, how to microdose it the right way, when to use it, as we're talking about. You don't have to wait for somebody to help you. You
Right.
could help yourself. So,
Yeah.
yeah. I mean, this is all the beginnings of pregnancy. And then as we move forward, most women also have read, well, I'm just going to use a lot of insulin and I'm going to have a big baby by the end of pregnancy. I mean, that's a generalization that is, it's stuck, even though people are fairly well educated now about what, because of the resources online or
Mhm.
things read or questions they've asked in online forums and whatnot. But I still think that there's a, once you transition into resistance, right? Moving into maybe trimester 2, or more so, what I often find is more mid trimester 2,
Same.
right?
Yes.
18 weeks, 20 weeks forward is really, resistance is here because you can bolus and take a light walk and your blood sugar just looks lovely. You don't have a low anymore.
Right. Yes. And you'll
So,
notice your pre-bolus timing needs to get longer and longer and longer, which is no fun for anyone, but that's reality. I like the beginning of second trimester though, because for many women, the nausea, if they do have it, is starting to calm down a bit.
mhm.
And the dropping insulin needs have kind of steadied themselves. And
Mhm.
then there are a few weeks in there. Sometimes it's only one, sometimes it's really almost a month where we're just doing minor adjustments. There's nothing drastic really needed, nothing really exciting going on in the world of glucose management, which is
Right.
just it's really nice.
It
And then
is. You often find is that that drop off for the women who do have a drop off in insulin needs by about, 13 weeks begins that second trimester, right? And by about week 15, 16, you're very likely to come back up to where you were maybe pre-pregnancy,
mhm,
overall doses. Your fatigue at that point also, I very, very much remember just not feeling tired I woke up one day and I felt like I had been rested. I got up and I just felt like me again is kind of how I remember that time period.
it's this
Mm.
thing where a lot of women will start to resume more of their pre-pregnancy regular physical activity if they
Yeah.
had sort of dropped off out of just sheer exhaustion. They will
Yeah.
start putting it back into place again because the energy is coming back, which is
Mhm.
lovely. Like
Yeah,
that.
it is quite nice. I mean, at that point too, if you have had food aversions or anything in the picture, you may be able to modify back to the meal planning or the type of, eating plan that you had felt really good about pre-pregnancy or the meals that you had worked out. Likely you have an appetite for them again. And then as things kind of shift, not only are you maybe able to add your exercise back, you're eating a little bit more regular, maybe back to healthy, more lean kind of content of meals.
Yeah.
But as you shift through the second trimester nutrition perspective, by the end of the second trimester, I often find a little bit of a need to cut back on carbs to contain those post meal swings,
Mhm.
despite the pre bolus getting longer.
Yeah.
And boosting up protein, I think protein doesn't get enough emphasis in pregnancy. Our body is not only building another little human, but that also takes a lot from our own body. And
Right.
so, from a bone health, a muscle preservation, and overall long term health post delivery, if you're planning to nurse, keeping your protein needs higher during pregnancy and cutting back, getting a little leaner in the carbohydrate can really help to keep glucose more stable and
Yes.
edge out some of those spikies that are concerning to you,
Correct.
while also, on a nutrient level, providing kind of what's needed, right?
Yeah. And focusing in on if you aren't necessarily a vegetable person, sometimes people say that, like, I really want to like them, but I just do not. This is a really good time if you're not dealing with nausea and your appetite is increased to try experimenting with some vegetables again. And so, Jenny mentioned that you're growing a human being. And I like to think about it like literally what you're putting in your mouth turns into your baby. So that
Yes.
helps. It helped me anyway, think about, okay, even though some of these things seem really, really yummy right now, I'm going to focus over here on things I can tolerate. Maybe I don't love them to death, but I can tolerate them because holy vitamins and minerals and fiber and all the things, antioxidants, all the
Right.
things that I want my baby to be made out of. So
Yes.
if there's a way to focus in on getting more plant focused eating
Yeah.
patterns, it can really pay off in the long run. Short
Mhm.
term, just providing you with your own body's nutritional needs, will feel better, more energetic if they have vitamins and minerals from plants in their body, right? But also it helps with insulin resistance.
Mhm.
And so somebody who's really focusing on protein and low carb, but they're not incorporating vegetables into their diet very regularly, they're going to be more in an inflammatory state. They're going to need more insulin than somebody who is also pulling
Right.
in some vegetables in their meals.
And digestively too, we know that in pregnancy, digestion slows. There's more ability in that slowed digestion to pull the nutrients out of the food until it gets to the point where you have to go to the bathroom, right?
Right.
But it also means pregnancy, a lot of women experience a fair amount of constipation. And if
Yes.
you've had extra iron added because you are on the mild kind of level of anemia during pregnancy, iron definitely creates a little bit more issue with constipation. So as Tavia is saying here, the value of plant-based, your fruits and your vegetables especially,
Right.
focusing it on all of the wonderful color vegetables, you're also going to get the fiber that helps to bulk your stool in the right way to allow you to go to the bathroom without having to take fiber supplements.
Right. And help you to try to prevent hemorrhoids, which is
Yep.
also fairly
Oh,
common during pregnancy because of the constipation that can occur.
what happens after all of that fun?
Right. So we're sort of shifting into third trimester talking about constipation and all that good stuff. It's not a full conversation unless we talk about bowel movements ever, is it? I don't know.
Not ever. No.
So third trimester, we are going to be working on getting enough insulin in at the right time to help your glucose stay in that nice, tight pregnancy target range as often as possible. And we are going to be focused on eating in a healthy way, helping support your goals with eating in a healthy way. Just like Jenny was talking about, if you hadn't yet, it's a great time to start cutting down on carbs if you're eating a little carb heavy, and focusing on the protein and the veggies to help with glucose management and to help support healthy fetal growth. So if somebody does ultra low carb, lots of saturated fats, actually babies can grow too big from that because they will take your triglycerides and grow from them. If
Yeah.
somebody eats high carb, that's going to support extra fetal growth because of all the extra insulin needed
Yes.
and the carbs converting to glucose. Babies make their own insulin during this process. And so if mom's glucoses are elevated, or if mom is consuming more carbs or high amounts of saturated fats, then that can lead to babies growing bigger than desired. And
Hmm.
so goal is to help avoid that and provide the right amount of nutrition, the right amount of insulin to balance all of that out along the way.
Yep, absolutely. And in terms of nutrition, I think it's an easier time to make some cutbacks because as baby gets larger, baby is usually also sitting a bit heavier on your digestive system. There's a really wonderful YouTube. It's an internal focus on the mother's body as the baby grows and develops. And it's a cool video because it actually shows what happens to the mother's organs as the baby grows and gets larger. It shows a shift in the organs and how much they get like squished. It's an amazing
Yeah.
visual of this is why I can eat 4 tablespoons and then I am full. But
This is why it takes me 25 minutes longer to go to the bathroom because you have to
yeah,
s through that to get out. Like, you can see what is going on, and it is a great video. So
yes.
so insulin resistance, changing timing of doses to better manage that longer digestion curve and increased insulin doses. Sometimes women end up on even triple their pre-pregnancy doses by the end. And if you didn't know that coming in, it's sort of terrifying, right? Like a lot of people have a dose in their mind, like, I don't take more than this much at a time at a meal. And we have to work through that along the way because that amount
Right.
will definitely shift in third trimester for most women.
And you'll find, as I mentioned before, as you move through pregnancy and you're able to potentially continue to be active, right? I found, especially my first pregnancy, I was working evening time, working with integrated diabetes, but during the daytime, I had a clinic job.
Mm,
And I walked back and forth to work most days of the week. And it was about a 2 mile there and 2 mile back in the late afternoon. But I remember in third trimester, I could bolus for my breakfast and I could have 5, 6 units of insulin on board, walk out the door. The first couple times I did it, I was all packed with like glucose and all of I'm like, I'm totally going to go low. Nope. It was flat. It was as if had I not walked, I would have actually needed more insulin than
right.
that to cover the meal. And in a different kind of spread out way. And that's where some of our, systems today, the smart features of them like Tandem, you can use extended bolus to your
Yes.
advantage in the third trimester from a digestive standpoint.
And you
You
can
can,
use basals to help with that too, which is
yes,
lovely. Very, very helpful.
yeah. So, all the things that we have to keep a watch on.
And often during, if we haven't yet, by third trimester, that's where Jenny and I start getting really out of the box creative with
Mhm.
maybe some adjunctive therapies.
Right,
So, for example, and it typically actually by first trimester, usually we're talking about how do you get the most rapid acting insulins possible that you can get covered by your insurance, because
right.
having the ultra rapid ultra rapid acting insulins, said in air quotes, can help with the pre-bolus timing,
Right.
shortening pre-bolus timing, making it more manageable, but also it helps with catching the rises. So we
If there's
recommend that
a
early on.
picture where you couldn't have pre-bolus because you didn't know if you'd even get to the whole meal, if you have
Yeah.
something that's working, 30 to 50% faster with the more ultra rapid actings, it
Mhm.
can help to keep that spike down. But by third trimester, there's another reason for it, and it's resistance.
Right. And often we'll even go to concentrated insulins, and we
Mhm.
might recommend adding on inhaled insulin or long-acting insulin or all of the above, depending on the situation to help people really get optimized management.
Yep.
And that layering of different types of insulin, it makes the regimen more complex. There are more pieces to it, more prescriptions to fill at the pharmacy, more interactions with the prescribing providers for the person who's pregnant. But usually people say, "Oh, I wish I would have just heard what you said a few weeks ago because this is so much better." Like, this is
Yeah,
working so much better.
it is.
One thing we didn't touch on is diabetic ketoacidosis or DKA risk during pregnancy. So
Yeah,
why?
valuable because it can certainly happen at much lower glucose than what we've usually been taught about DKA or ketones,
Yes.
right?
So we mentioned already that it's important to have glucagon. It's also important to have ketone testing at home. Many people who've lived with type 1 long enough, when I ask, "Do you have ketone testing at home?" will say, "I think it's in a drawer somewhere. It's probably expired like 5 years ago, and I
Right.
never check for them."
Do you find too that many people still have the urine ketone test? And as you said,
Yeah.
they probably opened it 5 years ago and haven't considered using it again. And then
Yeah.
it brings in the conversation of, well, we shouldn't be using those anyway, unless
Right.
in a need, right?
Right, right. When are some times that during pregnancy, so outside of pregnancy, we would
Mhm.
have people check for ketones if they have any signs or symptoms of illness, especially if there's any nausea or vomiting involved. If glucose is above a certain threshold, like a very elevated glucose is another common time. Inside of pregnancy, when do you have people check for ketones?
Yeah, inside of pregnancy, certainly with our automated insulin delivery systems and in automation, we do know that all the systems have a give and take of insulin,
Hmm.
right? And
Yep.
so definitely a time when the insulin has been suspended for a fair amount of time,
Mhm.
despite glucose looking like it's in the right target range or nowhere near high enough
Right.
to actually have a problem with ketones. That's a more prime time to say, let's actually check because that insulin deficit could potentially have a start of ketone development. It's not going to be DKA
No.
typically if you catch it fast enough, but that's one of the times. And then any time that there has been a pump failure,
Right.
whether it's
Or
the site.
if you suspect it's the pump not working, like the site might not be working, and so
Yes.
if you're following a system and a process, it's rare that your glucose is going to be very elevated and stick up there.
Yes.
Normally, if you say you ate at a restaurant and you did your best estimate and it didn't work out, you know how to get your glucose down pretty quickly. It's usually within a couple of hours where it's reasonable again. And if instead, an hour after you're doing what you normally do, it's going up or it's not coming down, we
Right.
will want you to check for ketones. And if ketones are present, we're not going to mess around with that. But there's no more like wait and see what happens.
Right.
So we teach. Oh, go
Another
ahead.
time that reminds me is because of the large amount, as you mentioned, many women have almost a tripling of insulin need by the end of pregnancy. And so we end up having very saturated sites for many
Yes.
women who have high insulin needs like that, a
Mhm.
basal rate of 1.5 or 2 units or more per hour, and bolus doses that are 10 plus units consistently over and over through the day. As you were saying, if the site looks like it's not responding and what's happening is not what should be happening, sometimes it's relative to the absorption of the site and needing to change it more frequently, but then also it's a great time to check for ketones.
Yes, agreed, agreed. And then Jenny and I both use some strategies to help women get their glucose down quickly if it is very elevated
Mm.
or if ketones are present. So we would get into that in an individual visit to help
Right.
people safely get that down
Yep.
quickly.
You know what I think is kind of prime to also talk about really is during preconception, you have put together a good team, right?
Yes.
hopefully you've put together a good clinical team that you know who you're going to for what piece and what check-in and what question to ask. But I do find that even if those are well-known people to you, how you may talk to your clinical care team shifts as you go through each and every trimester, right?
True.
From
Yep.
first trimester and maybe some testing and things that are going to look a little different into second trimester, where some more high risk kind of evaluations get done. And then definitely by third trimester, the weekly visits with your team should prompt good communication between you and your team. So, what are some of the things that you, when you're working with somebody, that you kind of find helps to prime them for that conversation, not just lets them sit back and listen to everything be thrown at them rather than to have kind of that back and forth?
Well, one thing that I for me, I like lists. That's how my brain works, so I don't miss something. So Jenny and I, we created a pregnancy kind of a guide checklist for us as we're working with clients. So
Hmm.
early on, when we first meet, we have some specific topics we cover and provide education on. And that I think helps as we move through the pregnancies with our women, then they are prepared to learn about the pieces that they might not have known they had to think about in the first place, but also then they have a better opportunity to come to those visits with their OB or their MFM team with questions that they have. For example, we're in third trimester right now, so we're talking about, planning for labor and delivery. So
Yes.
if you know this is what typically is planned, then you know to ask certain questions. And we'll get more into labor and delivery in our next session. So we'll
Hmm.
talk all about it in detail at that point, and postpartum care for mom
Yeah.
and moving beyond after that, right? With
Absolutely.
navigating diabetes all in the mix. But
Yeah.
those conversations sometimes, so if someone has a pretty open relationship with their prescribing providers, like their OB or their endo or their MFM as it may be, it's pretty easy for them to say, hey, my therapy isn't working as well. And I'm working with integrated diabetes services, for example, and they are recommending this other insulin
Hmm.
or this other system, AID system, and I'd like to try it out. And
Right.
and that's ideal. So that's the best scenario. And some healthcare provider teams will want us to send summary notes, which is also very helpful. So we can clearly communicate. We're available to answer questions from their team or
Hmm.
clarify anything anytime. Sometimes they'll get, and some clients have systems that they work within that are very protocol driven, and those
Yes.
systems can't really veer outside of the box. And
Hmm.
that makes the conversations more challenging for our clients. But I find most of the time, if we provide clinical rationale, we attach a couple of research studies that support what we're recommending. Most of the time, if the pregnant person is willing to pass that along, or we can send it to the physician office,
Right.
then they can get what they need for optimized care.
Most often it takes the right kind of information
Mhm.
to allow that conversation to be a nice back and forth rather than a directive from the care team. Like you said, they've got a protocol and they're going to follow that protocol. But if you come to them with really good information, about, well, why are you telling me to do this? Like a common one, and again, we'll talk about labor and delivery, going forward. But a common one is, well, we deliver everybody at 37 weeks or 37 and one or by 38 weeks. And that's where some conversation early enough needs to get started. And the comfort does have to come from the woman or the couple, right? To bring in and say, but look at how well things are being managed. The baby is growing well. Like, you have to point out things that you would expect are just visible to them because they're clinicians. But if you bring it up and you point it out, they're more likely to then want to talk about that with you and maybe very often actually see your point
Right. Yep.
and have some other considerations.
Yeah. And often, if there's someone, for example, if they're working with us, they've been managing their diabetes very well throughout the pregnancy. And so, if there is some hesitation from a care team that hasn't worked with us or heard of us before, then with solid weeks and weeks and months of really excellent diabetes management, it helps earn the trust that they
It-
need to
Mhm.
then say, okay, we've never done that before, but so far You've got this excellent management history working with this team. So, okay, I guess we'll try it. I've never done this before. We don't do this here. We'll try this. We'll do it for a short term trial. And that's always, if we're talking about diabetes management options, like which insulin to use or what pump to use or something, that's often a way to present it too, is just, I'd like to try this out for a couple of weeks and see if it does help me with what I'm trying to achieve so
Right.
that it doesn't seem like it's a long term commitment. There's minimal risk because it's short term. That's a nice way to throw it out there.
Not often, but I think we both, even in other practices that we've worked with, have certainly worked with women who have had kind of needs based on what they're able to be provided with in terms of their equipment, their technology, even their service team. They may have a service team that they didn't pick, but is on their preferred plan or their provider list, or their based insurance, their state-based insurance or whatever. And so, we have definitely helped women navigate in many different circumstances. And it is all advocating to what their need is and helping them to get the best that they possibly can get, no matter, kind of where they are with what they're doing.
Agreed. Agreed. All right. I think this is a great place to conclude for today so that we can leave space for talking all about
Labor.
navigating labor, planning for labor and delivery, glucose management before, during, and after delivery, and the several weeks postpartum, talking about how insulin needs will change and breastfeeding if that's an option. Of raising a human being and still trying to navigate your type 1 in a responsible, safe way.
Especially for those who, this is a first pregnancy, right?
Yes.
Because there is a lot that shifts and changes from a very self-centered life to
Right.
one that now includes someone who needs your everyday hand holding. And there's a lot to talk about. So I
Yes.
certainly look forward to having that next conversation with you so that women are fully prepared across the 3 trimesters and the one that follows, which is the postpartum time period, right?
Yes.
And
Yes.
as always, as obviously you guys can tell that we both work heavily with women pre-pregnancy and during pregnancy, and many times for a number of months after delivery too, just to help navigate everything back in. So if there are questions, anything that we can certainly help with, or need somebody extra to help advocate on your care team, please reach out to our integrateddiabetes.com and see if one of us might be a good fit to help you along your journey.
Absolutely.
Thanks, Tavia.
Thanks, Jen.
Thanks for tuning in to Think Like a Pancreas, the podcast. If you enjoyed today's episode, don't forget to like, follow, or subscribe on your favorite podcast app. On behalf of Think Like a Pancreas, the podcast, I'm Gary Shiner, wishing you a fantastic week ahead. And don't forget to think like a pancreas.